Hi everyone, I think we're live. Yeah, we should be live now. I hope our connection holds out. We've just had a little bit of an alert saying the connection was maybe a bit dodgy, so give us a shout if you can't hear anything or if we break up. Nice to see people joining. Hi everyone. So I'm Amy, I'm the head of Laboratories for Care Fertility in the UK, and I'm joined...
I'm Victoria Sephton, I'm the Group Medical Director for Care for the North region.
So we're on for about half an hour. We're planning to answer quite a lot of questions. I can see someone's asked, can we ask questions? Yes, you can. Please post them in there and I'll try my best to keep on top of them as they come through. We've got some that have come through already via email, so we'll get round to those as well. But first of all, just to go through what we're going to talk about really. So the session this evening is all about optimising fertility treatment, and we're running a couple of sessions this week because it's Fertility Awareness Week, and there's loads of things going on Instagram, loads of places for you to get tons of information about treatment. So we're just one of many out there. So today is all about optimising treatment. We're going to go over some of the tests that we offer on top of standard treatment, things like the SOS test, the Care Unity test. We're going to talk a little bit about lifestyle, and then we're going to answer some questions as well. We've got other sessions running this week from a few other people around the group. So on Wednesday, we've got a session all about egg donation by two of our donation experts, Julie and Lisa. They'll be joined by a couple of special guests, so that should be interesting. And then on Friday, we've got a session all about PGTA and Care Maps AI by Alison Campbell and Nicoletta, who are our Chief Scientific Officer and a consultant from Manchester. So that should also be really good. What that means is we're not going to touch on PGTA and Care Maps that much tonight, because it is going to be covered in another session. So if you have specific questions about that, if we've got time, we'll try and answer them. If not, then tune in to the session on Friday and you should get all of the information that you need about those on there. So we've got tons of people rolling in, so that's good. So we'll get started. So shall we have a quick chat first of all about Care Unity?
Yeah, sure. So quite often when couples come to care, they may have had treatment elsewhere, and they may be looking for some additional investigations because they've not been successful. And some of the things that we can offer that may not be available in other clinics is one particular test which is called Care Unity, which was actually devised and launched by our founder in 2018, I think it was. And this is a genetic test that there is a gene mutation on chromosome number 4, which is responsible, that gene is responsible for making the protein annexin 5. And that protein is very important in how the placenta develops, both in the very early stages of implantation, throughout the first trimester and into the second and third trimester. So if the sperm or the egg carries that gene defect, then you can have placental problems. And in terms of IVF, that can result in implantation failure or early miscarriage. And then later on in the pregnancy, it can relate to placental insufficiency or placental abruption. So this test is quite a simple, straightforward test. It involves taking a DNA sample from the inside of your mouth, and then that test goes off to a lab in the US that will look at that specific gene defect. And if either you or your partner carry that defect that are using the egg or the sperm, then we normally recommend that we start a low molecular weight heparin injection. You might have heard of it, the taxane
protein,
or,
right?
Yeah. And that will help to improve, to try and mitigate that problem that the early placenta might have because of that gene defect. So it does sound quite technical, but we do have lots of literature about it, and we give you literature once you've achieved that pregnancy and you've got to continue on into your obstetric care, so that your antenatal and your obstetric care team can look after you and understand why you're on that injection of heparin to try and protect that placental development. So, and you know, I think there's lots of people who come and say, oh, you know, I've never heard of that before, and that's a test that we designed back in 2018 with the lab in the US. And so it is something that we can offer to help couples who may have had failure previously, and we can optimise your treatment cycle with us.
So it's not a test that we do as standard. We offer it to a specific.
Yeah, we normally
group of
offer it
patients,
to
don't
recurrent, well, what is termed as recurrent implantation failure, which is in some settings it's 2 or more transfers or 3 or more transfers, depending on some of the terminology.
Yeah.
But essentially, if you've had 2 or 3 good quality embryos transferred without a positive pregnancy test, and we've not yet achieved implantation or a successful outcome, then that's where we would offer it. That's not to say that patients can't request it, but that's the specific group where we would generally start to offer and start to talk about it.
Yeah, I can see someone said they had the test and they've started on the treatment. Yeah,
that's right. So Inhixa is just a different trade name for the heparin.
Yeah.
There's Fragmin, Inhixa, Clexane. So best of luck. That's great.
Good.
Yeah, so that's Care Unity, and it's you know, we give you lots of information that we can put on the portal so that you can have a read of it before you decide to have the test. And as I say, it's very straightforward.
Brill. Okay, so we'll move on to another test that we offer, which is the sperm oxidative stress test. So this is obviously aimed at the sperm providers out there. Ordinarily, before treatment starts, we would do what we call a diagnostic semen analysis, and we would look at the sperm down a microscope and see how well the sperm was moving, what they looked like, and how much sperm there is there. What we can't see about the sperm when we look down a microscope is what the DNA looks like, or the chromosomes. And sometimes, although the sperm look like they're doing everything that they should, there might be something else going on in the chromosomes that we can't see. If there is something going on with chromosomes, what we call fragmentation, so the chromosomes have started breaking down and they're not operating the way that they should, this can sometimes be exhibited as oxidative stress. So we have a test that we perform called the oxidative stress test, and all this does is measure that level of oxidative stress in the sperm sample, and that tells us if, although the sperm look like they're moving well, the right number are there and they look good, it tells us if there's something that we can't see down a microscope that might be affecting the ability to fertilise an egg or create a pregnancy. So it's something that we've been doing for a number of years. It's relatively easily accessed. Every clinic offers the test, every care clinic, and the results are instant. So you can have a consultation very soon after the results are there. If we realise or we see that your oxidative stress levels are high, then we can provide treatment for that in the form of antioxidants. And that's usually a 3-month course of sachets that are helpfully flavoured blackcurrant to make it easier. And you take those every day for 3 months, and then we retest the oxidative stress. So that's another additional test that we can do for couples where they may have tried multiple rounds of treatment, failed implantation, or there is a sperm parameter that's slightly lower than we would expect. We could do the oxidative stress test to tell us if there's that fragmentation level that we want to try and treat. And then if we have a result where the oxidative stress is high and we treat that or attempt to treat that with antioxidants for 3 months, but that oxidative level stays high, which sometimes it can, sometimes the antioxidants don't fix the problem. We can offer something called Zymo in the actual treatment cycle. And what Zymo does is it's a little method of selecting the sperm in the lab for the embryologist to inject into the eggs, and it's supposed to select the sperm that have got low DNA fragmentation, i.e. low oxidative stress. So those two, the SOS test and the Zymo test, or the Zymo treatment rather, kind of go hand in hand with one another. And if we think you're a candidate for the oxidative stress test, we may recommend doing the Zymo test in your subsequent treatment.
So it's like the sperm will self-select. The best swimmers reach through that little, you make them swim through a little membrane, like an assault course.
That's right, an assault course, that's the best way of saying it.
So the best ones that reach that top are the ones that you would then choose to inject into the egg, because they're obviously the most competent sperm. I think someone had just been asking about how much the Care Unity is, and I think Chloe, who's manning the messaging, has put that on there. But if not, then you can go to our care fee schedule, which is updated regularly, and it's usually a couple test, so that you can both be tested together, and it's around about just over £200, I think, but it is on the fee schedule as well. And someone had also mentioned that they had level 1 and 2 testing, and is that the same as the Care Unity? That's not quite the same. That is looking at specific parameters within your blood in terms of clotting, because we know that a third of women who have recurrent pregnancy loss can have specific antibodies and abnormalities with the clotting and the way the blood interacts and clots in that early pregnancy phase. So that level 1 and 2 testing is another reason why you may be placed on a heparin injection, but it's a slightly different reason for the testing and a different test. So it is separate to the Care Unity.
Someone asked if the SOS test is the same as DNA fragmentation testing. It's not. Oxidative stress can often cause DNA fragmentation. So by testing for oxidative stress, it gives us an indication of if there is that DNA fragmentation present. So it's not the same test as a DNA fragmentation test, but it's kind of a proxy for DNA fragmentation.
Okay. So I think on some of the questions that had came in as well, there was some questions about endometrial testing and looking at what we can do. We focus very much on the embryo and getting the embryo the best quality that we can make it.
Because that's important.
That's very, very important.
It's 50% of it.
But there's also the endometrial factor and where we're putting that embryo. And as you know, when you come through treatment, we scan and we make sure that the endometrial thickness looks the right level for the embryo to be transferred. But we can't tell what's going on a molecular level in terms of what's actually happening in the lining of the womb and where we want to put that embryo. So there are some tests that we can do called an ERA, which is an endometrial receptivity assay, and an Emma and Alice test. And those 3 tests together are called an endometrio test, as it's 3 separate tests. The Emma and Alice part look at the endometrial microbiome, and they look to see if there is the correct balance within the endometrium of all of the protective flora that should be there, which is positive for implantation, and to also exclude any abnormalities in terms of the endometrium and in terms of abnormal pathogens that shouldn't be there, that might be causing a chronic inflammation process within the lining of the womb that isn't clinically evident, but on that very granular molecular level would potentially prevent implantation or be linked with early miscarriage. So the ERA is the part that looks at when your window is specifically receptive for you, and most women would have a receptivity window of around 120 hours after their ovulation surge or they start progesterone, but some women's window is quite significantly displaced, and if you miss that critical window, it could reduce the chances of implantation. Again, the microbiome assessment is important in terms of informing us that we've got the correct balance. When we do that, it's a biopsy of the lining of the womb, and we do a mock cycle so that we can replicate exactly what would happen as if we were putting an embryo in. We take a sample of the lining of the womb out, so that when we know we come to do your embryo transfer, we can actually say that we can replicate the same exact protocol. And we send that sample off, and the lab tells us this is the receptivity, this is when the embryo needs to go back in specific to that individual, and this is whether you need antibiotics to clear a subclinical infection, or whether we need to actually promote balance and give probiotics in the microbiome to give those very positive the positive microbiome for implantation. So that's another test, and lots of the current evidence, and there was just some recent evidence and studies that have been actually presented last week in the US, looking at, is ERA suitable for everybody? And in fact, there's some evidence to say that it's really for, again, that population where they might have had recurrent implantation failure. So if you've had 1, 2 or 3 replacements of good quality embryos and you've not yet had a positive outcome, then that's again where we'll be starting to talk about we need to look into the microbiome and the timing of the embryo replacement. It is difficult because big studies can be difficult to interpret the data, but the consensus is its biggest benefit is in that recurrent implantation failure group. That's just the receptivity window. The microbiome, if you unlink that, is slightly different, and that can have a positive benefit in all aspects in anyone's treatment cycle. So that's part of that endometrial factor in terms of what we can do to assess where the embryo is going.
Good. So should we touch a little bit on lifestyle? Because this session's all about optimizing success, and I think a really important thing is to get yourself into a good healthy place. I think that's going to give you the best chance.
And I think there's a lot, obviously a lot of the time there's lots of talk about BMI, and then vitamins, supplements, healthy lifestyle, in terms of a positive mindset and how you actually approach your treatment. Some couples gain a lot from coaching and mindfulness. Sleep hygiene is important as well. A regular sleep pattern is really important, and nutrition plays a large factor in terms of, particularly in women who might have polycystic ovaries and might have some insulin resistance, then nutrition also plays an important part in that. And we can give you plenty of advice so that's specific to you as a couple with regards to what we would recommend in terms of lifestyle and any supplements that we would recommend. Vitamin D is always a hot topic. We don't get enough of it. We don't see enough sun.
It's currently tipping it down and has been all day here.
So I think, that's a hot topic, and there's lots of positive associations with that. So those are important. But it's about having a healthy balance. And also not being too... don't deny yourself too much, and be too strict with yourself, because you're about to embark on a pretty tough time. And so if everything is restricted, you then it becomes much more onerous. So it's about everything in a balance, really.
Definitely. I think people say cut out caffeine, cut out alcohol, all of these things. Well, that can make you really unhappy. So sometimes it is a bit of a balance.
It's a balance in just having a really small amount and keeping it in check and in balance.
Okay, so we've had some questions come through that I think we'll try and get through. What's the BMI limit for treatment at the minute?
So currently for, the CCGs, which is the commissioning groups, they've now changed how they're organised, and they're now in what's called integrated care boards, and they have eligibility criteria, and the BMI has to be below 30 or below for NHS funded treatment, and across care for non-NHS funded treatment or for self-funded treatment, our BMI limit is 35 or below. Yeah. And the reason for that is based on once the BMI goes above 35, we do see that success rates reduce, as does your response to stimulation. So you may not respond the way we expect you to the medication to grow the eggs. And also obstetric complications increase when BMI goes above 35, and you're more likely to be at risk of developing diabetes in pregnancy or blood pressure problems. So it's taken based on the longer term aspect of our end game is to get you pregnant. We want a healthy pregnancy, and so in order to do that we need to have a limit where we know that the risks jump up beyond that.
Yeah. Does the BMI relate to male patients as well?
It can impact the oxidative stress, as you spoke about before. So a BMI above 30 in males can be associated with an increased oxidative stress on the sperm. And so again, it's about just optimizing the BMI as best as possible.
What thick...
But sorry, there's no eligibility for males, okay? So, so it can impact, but it doesn't...
It has an effect, but there aren't any limitations as it stands on male BMI for treatment.
Now, someone may actually catch me out on that, because I obviously only know our ICBs in the north.
Okay, yeah.
And there may be some, it's not one policy for all across the UK.
And there's so many of them.
And there are so many.
And they all have their own rules.
There may be some out there that do have a male criteria for BMI.
Yeah.
But at the moment in the north, it's not there.
Yeah.
Sorry, someone's asked what's the CCG. It's a care commissioning group, but now they've moved to what's called ICBs, which is integrated care boards, and they are responsible for deciding what's funded in terms of fertility treatment.
Can your progesterone level and or thickness of your lining be too high or thick for transfer?
So that's two questions.
Sorry, rolled into one.
So the thickness of the endometrium is a difficult one, in that everyone's an individual, and you can have variation within one woman from one cycle to the next. But we would say that if we've done a baseline scan and we know that the endometrium looks essentially normal, and the lining is where it should be for that time in the cycle, because it changes through the cycle, then once it goes above 20 or 25 millimetres, we would know that would actually be abnormally thickened, because it shouldn't necessarily reach that far that fast, and it may suggest there's an underlying polyp. It's unusual that it would develop in a short space of time, 2 to 3 months, but it's something that we would say it can be too thick, but it's really indicative of something else. And it's really you would normally have tracked it, and then you would know that suddenly got too thick, if that makes sense. The progesterone level, our research fellow did a really important study, specifically in terms of frozen embryo transfers, and when you're having progesterone, when you're taking it either as a tablet, pessary, or an injection, whether it can be too high and what the absolute minimum should be. And across care now, we would check in frozen embryo transfer cycles. We have just launched that we would check your progesterone level ahead of your frozen embryo transfer to check that it falls within the right parameters, and make sure it's high enough to get to match to the best outcome. It's difficult to say what's too high, but in the study that was conducted across the whole of care, once you went above 90 or 95, it was very difficult to say that mapped to a good outcome, because it just, the way the graph went, it wouldn't give you any meaningful information.
We're back.
We know that the sweet spot for the best outcomes was between 30 and 52 millimoles per litre when we checked progesterone level ahead of transfer. Yeah.
And would you check the progesterone in both stimulated and natural cycle frozen embryo transfers? There's just a lady, someone who said that they didn't have their progesterone.
So in a natural cycle, we can do it. Obviously, we would do it. What we're doing at the moment is rolling this out across the group. So not all clinics have yet adopted that. The new policy went in about 4 to 6 weeks ago. So it's just making sure it really fits with more of the stimulated cycles than the natural cycles, because you're producing your own natural progesterone. But we can do it, and the data is there to tell us what it should be for a natural cycle. Yeah.
I'll connect. Maybe that's a sign that we need to stop talking. We've got a couple of minutes left, so we'll try and answer some quick questions. They're mostly clinical, I'm sorry.
Okay.
Should you have surgery for fibroid removal prior to IVF?
Oh, that's not a quick answer.
See your specialist.
Right. No, I mean, it really does depend on if there's a single fibroid, how big it is, the location of it, whether it's compromising the lining of the womb, and if it's multiple fibroids that are making the uterus really enlarged, that would then make a pregnancy very difficult, then yes, there are definitely certain situations where fibroid, multiple or single, should be removed. But if they're very small and on the very outside of the womb and not interfering with the cavity where the embryo needs to develop, then often we would leave those alone.
Yeah.
And if you do have to have removal of fibroids, it doesn't mean that you can't make your embryos first and freeze them and then go on and have your surgery. If you're worried about delaying and your ovarian reserve declining whilst you're waiting to have the surgery, you could always have your egg retrieval, make your embryos, freeze them, and then you know that bit's done, and then you can address the fibroids.
Yeah. Is metformin worth trying to aid in conception?
Metformin, there's been lots of information in the past about this, and it's only really beneficial for a very specific group of women with polycystic ovarian syndrome who have altered metabolism that would need the metformin.
Yeah.
And I think you'd be best guided on an individual basis.
Yeah. I think that's a really important point with loads of these tests, is that they are so individual, and it's so depends on your personal circumstance, your history, your test results. You know, we don't just blanket everyone with the same. We would recommend things based on your circumstances. So lots of these things are useful, but only in a certain group of patients. Intralipids, are they worthwhile? Sorry. When we've got 30 seconds left.
Again, that's really controversial because you can interpret the data both ways. There is some evidence that it can improve in certain circumstances. Again, recurrent implantation failure, when certain tests have been carried out and you've got those abnormalities within those level 1 and 2 testings, that intralipids may be of some benefit.
Yeah.
But it's really tricky to say that it's beneficial to everybody.
Yeah. Can cysts form as part of a failed IVF cycle?
So cysts can form any time during a normal menstrual cycle when you're not even having treatment, and most often they will resolve spontaneously on their own with the next period. When you are stimulating the ovaries, you can create a cyst because that's really what you're creating for the follicle. When we create a follicle, when that goes above 2, 3 or 4 centimetres, that's when we start to term it as a cyst. So sometimes those follicles can get very big and they tend to be filled with fluid and not contain an egg, and that's when we would refer to them as cystic. And cyst just means a fluid filled pouch. So it's those a cyst on the ovary can develop due to the stimulation. It can persist after egg retrieval or refill after egg retrieval, and only if it's above 6 or 7 centimetres would it need to be specifically addressed and removed. Most of the time they would resolve spontaneously if they look simple and just fluid filled.
Yeah. So I'm just going to try and get through some of the other questions that are coming through. We'll carry on for a little while longer if people want to stay on and hear. 2 failed 4BB transfers, so that's a good quality embryo. Is there anything you'd recommend for implantation to go forward? I think that we've touched on a few things that would potentially help. It would depend what you meant by failed. Did they implant? Was it a positive test and then didn't carry on? Did it get any further than that? Certainly tune into the session on Friday about PGTA and care maps. I think they're 2 things that would probably really help in this circumstance. I read that embryo transfer is more successful after 5 days as opposed to 3. Is there truth to this? That's a really good question and a lot to unpack in a limited amount of time. At Care, we would always recommend a day 5 transfer because we feel like the information that we get from the embryos from those extra days of culture are really important for helping us inform you about the chance of success. It would tie in with having care maps, so tune into the session on Friday again if you don't know what care maps is. But it would be dependent on circumstance, and we would usually recommend a day 5 transfer. We think that is usually better. Are there any criteria for teaser? So teaser is testicular sperm aspiration, and we've not got enough time to really go through the ins and outs. This is a procedure usually used for men who don't have any sperm in their ejaculate, and we would run some tests. We'd check the hormone levels, we'd see if there was a blockage anywhere, and then we would do this operation where we would physically remove some of the tissue to see if there was any sperm in there. There is criteria where we would recommend having that operation. Obviously we don't want to do it where it's not necessary, so it would be as we've said numerous times, on a case-by-case basis. Yeah. There was a question really early on about a patient, someone who's had a stroke in 2020, and they've been trying for 5 years. Is IVF worth looking at for them?
So I think we'd really need to understand the functional limitations that the stroke has had and the impact, and what was the cause of the stroke. Because medically, stroke can be caused by a clot or a bleed within the brain. And I think we'd really need to assess whether it's safe for IVF to be performed due to the fact that you have very high levels of estrogen, and that can be associated with increased risk of stroke, depending on what type of stroke it was. So we would normally do a thorough medical assessment. We would normally ask for an obstetric opinion based on risk, and then we would be able to guide as to whether IVF was safe to go ahead with the stroke, with a stroke previously, and whether there was any limitations to that, but actually the longer term impact of pregnancy as well. Yeah. Because pregnancy is when you become pregnant, you are at increased risk of developing blood clots in your legs, in your head, in your lungs. So if it was a thrombotic stroke, then pregnancy could be a high risk factor. Yeah.
What are the implications of having a tilted uterus?
So about 30% of women have a normally what we call retroverted or tilted womb, and it's of minimal significance. It really depends on whether your womb leans forward or slightly backwards. unless it causes a very difficult embryo transfer where it's really difficult to get in because of that tilting, it really has very little impact. And we years ago, 20, 30 plus years, we used to fix the uterus and bring it forward, called a ventral suspension, because we felt that it might play a factor, but we've subsequently learned that it really doesn't have that much impact.
Yeah, and the scan would indicate...
We can see straight away on a scan
and
way, and then when we do a scan at the time of embryo transfer, we know that we're following the path into the womb correctly. So.
Yeah. There was a question, patients had 2 frozen embryo transfers and each time 2 embryos had to be removed because one didn't survive. Is that normal? Yes, embryo survival isn't 100% after freezing. It's pretty good. So in care, we have around a 97-98% survival rate for frozen embryos. But sometimes they don't survive, unfortunately, and it's potentially bad luck that's happened twice, but it can happen, unfortunately. Thyroid, there was a question about thyroid. I assume they said, can you get pregnant with thyroid? But I think maybe they mean by
thyroid issues.
Yeah.
So it is tricky when you have an underactive or an overactive thyroid, because we know that the levels of thyroxine and one of the other markers in the blood needs to be within a certain range to reduce the risk of miscarriage or failed implantation. So we would normally want to make sure that any thyroxine replacement that you're taking is at the correct level, so that we've got you in that good treatment range. Doesn't mean you can't get pregnant. We just need to make sure that your thyroid is being adequately monitored and the levels are in the correct range to make sure that we can reduce those risks of miscarriage later on.
How about a heart-shaped uterus?
Okay, so heart-shaped uterus is, again, quite common, and it really depends on the degree of the heart shape. So I'll have to use my hands again. So if you have just a very mild heart-shaped uterus like this, that is very limited importance. But if it becomes very, very dipped and almost to the point where it's got 2 separate cavities, and then it can... We need to know about that, because we need to know, can both cavities support a pregnancy? Is one more dominant than the other? Is the lining of the womb better in one than the other? Because you can actually have 2 full linings of the womb. So then again, we do a 3D ultrasound. We can see which way, which is going to be best way to move forward. What I should say is any uterine anomaly that deviates from the normal shape of the uterus, if it's only just a very small indentation, but if it is very significantly marked heart shape, any of those are related to a slightly increased risk of miscarriage in that middle stage of pregnancy after 12 to 14 weeks, because of the dynamics of the womb. But plenty of successful pregnancies have happened in heart-shaped uteruses.
Good. Well, I think we'll leave it there. There's still questions coming through, but we've got people behind the scenes who are answering them. And obviously DM if you have got any burning questions that you really want to have answered. I think the take-home message is personalised, individual treatment. It's all case by case. There's plenty of tests out there that we can offer. You just have to speak to the right people and make sure that you've got the right information to make those decisions. So thank you very much, and we'll hopefully see you again soon.
See you soon.
Bye.